Hi everyone, welcome to Sweet Spot Safari. I'm Ben and this is John, your hosts. Today's subject is curing and preventing. And today's explorer is John Tuppen, who spent 38 years in the health service. So welcome, John.
Thank you very much.
Great to have you here. Perhaps maybe we'll start with a bit about your background. 38 years is a long time in the health service, so I'm sure you've got a few stories to share. What's your journey here?
Well, I guess I'll start actually with my grandfather, because my family hasn't had any doctors before me. And the reason I guess I became a doctor was that my grandfather was in the Royal Army Medical Corps in World War One, and as part of a school project, I had to interview an older person and interviewed him. And the stories that he gave of his experience, just as a medical orderly, inspired a lifetime of learning. So having decided on medicine, I started at Manchester in '79. So 38 years is actually the sharp end, having qualified and earning some money, but there was another 5 years of learning to start with. And then having gone through medical school and qualified, I decided to become a GP. But being a GP is, it's like joining, or was at least, it's not so much now, but was joining a partnership was like joining a family. And hardly anyone moved between partnerships, so you were stuck for life. So I did a further year as a registrar in elderly medicine, and then went into partnership. And during that time, I've been involved in all sorts of different things, setting up fairly innovative services. So nurse-led clinics at hospitals probably 30 years ago, and forensic medicine GP support into a medium secure unit, fund holding, which was the first iteration of allowing GPs to hold partial budgets, and then got involved in the management side. So split my job life 50-50 between practicing GP and chairing the executive committee of a primary care trust, which I did for about 12 years. And I've been part of that sort of environment ever since, with input into national bodies and health authority boards and so forth in areas that have interested me.
So you've seen quite a few corridors, and you've seen quite a few some corners of the health service. So so it'll be interesting to pick your brains and actually learn a bit more about how it works and how it's not working. And I'm just thinking about your story about your grandfather. How is your experience with the health service? Has that influenced your children? Are they interested in the health service, or have they run in the opposite direction?
There's no way my son would be a doctor. So they have run in the opposite direction. He is in biological sciences and doing research, or part of a lab that's doing research into deformed proteins, which basically is the sort of thing that influences neurological progressive diseases, multiple sclerosis, motor neurone disease, Parkinson's, Alzheimer's. So he's cut of the same cloth, but has decided to take a very different route. Yeah,
it's interesting. So you talk about those neurological conditions. One question just to start things off is, the last 40 years, I'm guessing that there's been quite a big change in the health of our society, and probably the health of the system as a overall. What's your view on why so many people seem to be sick at the moment, and what are the consequences? What are the changes you've seen in the health service in that time?
Oh,
just a snapshot.
Yeah, absolutely. There's different sections to that, Ben. But could I just actually throw back to you? Why do you say seems sick?
What so seems sick. I can't remember whether that was about people or the system. Did I say that in terms of the people?
The people
Yeah.
seem to be sick at the.
Um, I think one of it, one is one of it is news related. So there seems to be just lots of talk of all sorts of different illnesses, whether it's cancers, whether it's neurological conditions, whether it's I live with ADHD, for example. So the increase in ADHD and autism and other related conditions seems to have increased certainly the last decade. Mentioned cancers. There's excess deaths, which we've got going on at the moment in a lot of Western countries. So yeah, I think it's just it's a kind of mixture of things, and part I sit on the board at Healthwatch, and so I kind of see quite a lot of data just in passing. So I guess there's quite a few different data points that I'm picking up on.
No, I was just interested because there are multiple factors. Let's dissect them a little bit. First of all, with an aging population, when I started medicine, people usually probably died of either their first chronic illness or their second one. Medicine has now advanced to the stage that people live for a long time with chronic illness and acquire many other chronic illnesses. And that has a huge influence on perception, because if you survive for, say, 15 years rather than 3 years, and you acquire more and you multiply the two numbers together, you see in the community a massive increase in the number that are perceived. So age certainly has one factor. The reason I ask you to qualify seemed is that certainly up until 5 years ago, before the pandemic, the average life expectancy and health of the community must have been improving because people were living longer. And there are diseases that I saw when I started, which hardly ever happen now. So, for example, in childhood, measles, bacterial meningitis were things which were really pretty prevalent. Now they hit the headlines if it happens because it's a failure of vaccination and a problem with the way that the system works. And the another reason for therefore the perception that there is more health is that I think the disease load in the community has to be viewed as you view an iceberg from above the surface. The amount that is actually seen is a fraction of the total. And what I think has happened is, if you like, the density of the surrounding water has increased so that people are seeing more disease and perceiving more disease, but the total, if you view the whole iceberg, probably hasn't. And the other large factor that influences people, Ben, you mentioned news. I would absolutely add in social media. The access and to so-called information and peer influence is enormous. So that if you look, for example, around teenagers with depression or suicidal thoughts. Of course, we saw them occasionally when I first started in general practice back in the 1980s, but it was occasional and would provoke a team meeting within the practice. Now, an average GP would expect to hear maybe 3 or 4 stories a week of children so-called suffering the same amount of a problem. The anxiety is real. The severity of the true medical problem probably isn't, and that particular part of the iceberg is certainly floating an awful lot higher.
That's really interesting you say that, John, because I could come on that one, having had teenage kids in the not too distant past. It does feel like there's like an exponential growth factor associated with social media. And as you say, I know you're very guarded with your words when you said information as opposed to reliable sources of information. You know, and we've seen it the way that social media at a cynical end politically has been manipulated too. So that's really interesting. We'd be interested to know how you actually get to the bottom of that in a stretched service, between differentiating between the perceived and the real, if that makes sense, John, you know?
Well, that part, I'll probably come back to this multiple times, but using someone with both extensive training and extensive experience as triage is something that definitely gives best results in my view, and that's also based in evidence, and yet systemically, what have we done? We've used lay people, NHS 111, NHS Direct, which cynically within medicine was called NHS Direct to the GP or to accident and emergency, and being so risk averse in the algorithms that these lay people then use, that it's further trained and encouraged the very behaviors that social media is triggering. And that has to be a system-wide approach to reverse that. And some of it means that the system, rather than the individual doctor or nurse or pharmacist or whoever, has to accept the degree of risk that goes with managing demand in a very stretched system.
So that's absolutely fascinating you say that, because I'm going to put my engineering head on there. And it's something that it's crossed my mind before, is whether these sort of so-called early intervention triage systems, the way they were marketed was to actually help effectively to reduce the load on the GP and the medical service. But actually, if they're not acting as a, dare I say, and I'm not being judgmental here, a professional or competent filter, in reality, in the end, they're actually pushing more down the funnel and creating potentially more bottleneck.
Yeah, absolutely. I firmly believe that. And in fact, I really do support a multi-professional workforce dealing with patients. Mm-hmm. However, if you look at the general practice experience, where you really don't know what's going to come through the door, every time that you have a nurse or a paramedic or a pharmacist, say, dealing with clinical problems, the amount that they deal with exclusively on their own is say 50% or 70%, depends on the method that you use them, but the amount that they have to come and get advice from a doctor remains significant. So that, and the time that is spent by the people doing their work is, if you cost it out by our hourly wage and worked it out, it's a fallacy that you actually get a saving.
Yeah, I get that totally.
The saving happens at the moment because, and again, I will, this isn't politically acceptable to an awful lot of people, but the real problem is that the quality of healthcare is plummeting, and that the number of experienced people to support the new style of workers is actually dropping, and you end up with a reduction in the quality. And rather than accepting that, and however hard it is, it's fact, and people realize now that if you look at the perception on health outcomes and health and general practice, it has really dropped significantly. So people do know that something's very wrong, and not to address it is just delaying the inevitable reform of a system that we will have to have.
So to me, that's absolutely fascinating. Again, I'm going to let Ben come in a minute, but I just want to finish things, because what you've described to me, if I look at my work in productivity and some of the work I've done with Japanese work and lean and everything else, what you've just described is an internal recycle loop, right? Which we describe as waste if I was looking at the manufacturing facility. And in fact, we actually call it the hidden factory, because it's the bit where people are doing effort, but not necessarily having an impact. And it's actually not having a positive effect on the bottom line. What he's actually doing is sucking up resource.
Absolutely. I would completely agree. So this is moving away from the original question about the perceived amount of sickness, but for the NHS, until the retention of experienced staff happens, and until the demand versus supply equation is addressed, we are in a serious problem.
Yeah. So effectively, we've got a virtual sticking plaster, which is not actually doing anything at all until we address the fundamental issues, which, as you say, is supply and demand, where you've got other health issues associated. I'm guessing we've not touched on it yet. You mentioned as well, things like diabetes and obesity and stuff like that, and also an aging population. So that demand on the system is going up and up, whereas the supply of professionals is going down and down.
Correct. And the response, whenever there is criticism or worry about the health service, the response is an immediate extra £1 billion or something, or we'll build another hospital, which probably doesn't ever actually happen. It isn't about a long-term planning. And so the problem with the delivery of health in this system, to my mind, the problem with that, it is much more about, we have to somehow have a societal conversation about accepting that for 15 years, because that's the lag time it's going to take to get things better, health is not going to be at a desired level. And during that time, we don't make knee-jerk reactions by building another unit or another hospital. We get a proper workforce plan. Now, part of a workforce plan, which is actually one of the very first that has ever been published by the NHS, has been issued after a 2-year delay. And the 2-year delay was because if you do things properly in health, the financial numbers get absolutely scary.
Yeah.
And the Treasury can't live with doing it properly because it's just unaffordable. So we've now got a partial plan which addresses training of staff, but puts yet more lower end workers in. Going back to the discussion we had just previously about productivity and your factory within the factory idea. So now people are going to be trained on the job to do the job, and that as an apprentice. And that the fear I have is that the workforce is so stretched, those apprentices won't be a true apprenticeship. They will be dumped in the deep end and left to wallow without actually having adequate training.
Yeah, because the people can't dedicate the time that they need to give them a structured and a proper apprenticeship, right, with a level of training, you know, academic work as well as on the job work, you know, because it has to be a blended solution, you know.
Absolutely. And you know, I hope I haven't hijacked the intention of what this was, because
no, because I think what it does is it provides amazing context and reality. You know, if we certainly look at the UK model, for instance, right, obviously other models around the world, in terms of you know, where do we go in terms of prevention and curing, you know. And I think if you, and again, I don't want to hijack the debate and I want to bring Ben in now, but I mean, I think most people logically would say prevention's got to be better than curing. I mean, ultimately that's a more of a cradle to grave solution, but it's more of a journey of how you get to prevention, and curing will never go away. Of course, there will be an element of it. What's the balance and everything else? So I think, you know, I saw Ben looking there very studiously. So I think, you know, and John shared a lot.
So Ben, is it okay if I go back to your comment about neurological diseases, but also look at diabetes? In terms of prevention, kind of focus more on clinical medicine rather than system design, if you like, for a while.
Well, I think they both interact with each other. But yeah, I think if we think about community health or individual health, that would be good.
Okay, so neurological disease probably is an outlier in medicine, in fact, in the sense that it hasn't moved that much in the time that I've been a doctor. So if you think about multiple sclerosis and motor neurone disease and Parkinson's disease, up until now, the prognosis and treatments have been very much partial and patchy. And if you look at some brain tumors, the prognosis probably hasn't moved at all, whilst most other cancers have had huge improvements. So neurological disease probably lends itself, hopefully, to the coming era of genetically designed interactions and other kind of pharmacology based on proper understanding of proteins and things, but hopefully will improve over the next 30 years. However, other bits, and we can just touch on areas like autism, things like personality disorders, which are incredibly prevalent if you look at people within prison systems, and therefore have a huge impact on health. The two areas which are really significant for those are early years of life, including from conception to birth, and the influence that things like poor nourishment or stress in the mother, smoking, other influences can have. And that should be modifiable, but the early years program and health visiting and things where, you know, if you were redesigning a system and wanting to look into prevention, with our current understanding, you probably ought to be investing a significant amount into those parts to eventually lead to better, healthy citizens that fit to a model which society wants people to conform to. So that would be one comment. And the other part regarding, oh, I've lost my train of thought for a second, sorry, it will come back, but
you mentioned autism, mentioned
yeah, sorry. So yeah, the other part which may or not may not get a look in is actually the importance of the microbiome of the gut into neurological conditions. And autism and multiple sclerosis and a whole load of issues are now thought to be hugely influenced by the microbiome of the gut. That's all the bacteria and viruses and fungi and stuff that lives with us, which then influences the way that the body reacts, and it can influence the immune system. And I have a friend, for example, who's researching at Imperial on glioblastoma multiforme, a nasty aggressive brain tumor which has not had any progress. Adjusting diet and the microbiome is being found to have a fairly profound effect on the way that conventional treatments then work. Now, the trouble is that microbiome is something that is about healthy eating and your environment, and it's probably influenced by a whole load of factors that are not yet known about, and certainly I don't know about. And my fear is that particularly doctors will be cynical of it and not actually grasp the opportunities that looking outside the box actually should give us.
Yeah, I think you know, is this part of, and maybe this comes back to the you know, there's a couple connections to maybe issues that we have specifically in the West, the way that we think, and one of those is yeah, the kind of difference between West and East, maybe that we have more of a reductionist lens, so we're kind of focused on, you know, the kind of, you know, specifics and parts of the human body. So, you know, we're very good on tackling specific areas of the body, whether it's through surgery or you know, three things that we kind of have been maybe our kind of savior in Western medicine have been you know, vaccines, antibiotics, and surgery. But obviously, if they're the only three tools that we have, you know, in our toolkit, you know, tablets, needles, and a knife, we tend to see kind of problems and illness through those lenses. Whereas maybe the Eastern approach, more holistic, seeing the body as a system, an integrated system where the brain doesn't exist in a vacuum. Actually, it's processing information from all of your organs, including your gut, which I think is, correct me if I'm wrong, which is where most of your serotonin is, in your gut. So that kind of makes sense. And I'm just wondering actually whether, you know, part of this sort of change is maybe integrating the good parts of the Eastern approach to health and how the body as a system environment you know, works alongside our focus on specific, you know, acute problems with our bodies. So I don't know if you have any, because there seems to be a bit of an allergic reaction when you kind of say about holistic medicine. That almost seems just as an impulse that actually that we should dismiss that. But, you know, is that fair?
Okay. Yeah, if you'd have asked me before your introduction then about holistic medicine, in coming from a Western trained profession.
Mm.
I think your initial description very much fits with the hospital system.
Mm.
And if we had a good primary care system still, I would very much hope would not fit with general practice, who as family practitioners do try to look at the whole, not to isolate body systems from the psyche and the psychology and the social interaction and so forth. I think because of the pressures on health, and maybe part of the training, I don't know, I've not been involved in that, but certainly we are in danger of losing that. And another major change that I've experienced is over the last 38 years would be if you had a difficult problem which didn't fit neatly into any diagnostic box. I used to be able to choose a good general physician who was thinking about all sorts of systems to send for advice. Consultants now are so trained down sub-silos of silos and divisions that generalist approach has been lost. Now, I think I don't know enough about Eastern medicine to really comment about it, but I think if you took simply the microbiome and merged it with modern medicine, and you looked at kind of early years interventions and took a much longer time span on illness, and you encouraged free thinking and expansion of those, then we would do future populations a big service. But my concern would be that as such a large amount of GDP comes from the pharmaceutical industry, and that isn't a pharmaceutical intervention, the mechanisms which fuel interest in them and which pay for the research and get people excited would not be there. And I can't see in the current political climates how an alternative mechanism would be forthcoming.
I think there's definitely a conflict of interest. Sorry, John. Just to follow up on my train of thought. I think what, and when I say holistic medicine, maybe I'm not talking about the just purely the herbs. I'm talking more the body as more the kind of body and psyche as a system, and the body in connection with our environment, our food supply, and everything else. And it does make me think about this transformation which you're talking about, which we might have to go on in over the course of 15 years. And I think the nature of where, and John and I have talked about this, as a sweet spot, the difference between shallow and deep. And I'm thinking about maybe kind of shallow in deep change, or shallow in deep health, that we tend to be very good at spotting surface level symptoms. We're not very kind of good at really understanding, or maybe we don't want to understand the deep root causes of a lot of our challenges. And that might be from an individual health perspective, that actually the system's just not set up. There isn't the time or resources to do that. But also it makes me think that the system doesn't want to maybe look at the root causes. And is it the responsibility of the health system to pick up the pieces of every other institution and system in society which is causing ill health? And whether that's the food supply and agriculture, whether that's the education system, whether that's housing problems, whether that's environmental challenges. I'm just wondering, is it fair that the health system is there to pick up all of these pieces?
Well, I think you have to look at the systems holistically, Ben, as well.
Yeah.
And what we are talking about is about a huge transformational change of the systems that underline departments of health, departments of education, farming, agriculture, all the rest of those bits. And whilst your deep and shallow is one bit, the bit that, to my mind, we're absolutely calling out for, and I don't know if this is a person or a program of works or advertising or propaganda, if you like, but what I'm pretty sure we need is the leader to even spark the concern in the population to allow that conversation.
I think you're absolutely right, John. I think that, if that's okay, I'll come back on a few things. Going back to this thing about perceptions in Eastern medicine, right? And I think we have to be a bit careful, Ben, in the language we use, because, as you said before, the holistic medicine, and there's the herbalists, and there's this. Now, it's interesting. I spent quite a bit of time in the East at the moment, as you know, right? And things are not quite as and it depends on the East as well. It depends on wealth too. I mean, wealth is a huge factor involved in this as well. Is that I think the understanding of the systems is really, really important, and particularly to your point, John, about the microgut. But what's actually happened in the East, or certainly in the Middle East, is they've adopted a lot of Western practices, right, in terms of intervention and surgery and everything else, because it's to a certain extent being linked to wealth. The other problem, of course, is they've significantly changed their diet. And I've seen this a lot from an Eastern diet, which they were used to a Western diet. And the obesity epidemic, we think it's bad in the UK and the US, which it is also bad out here considerably. And that's because they've gone away from their traditional diet to a more Western diet, which is more high sugar, high carb, and everything else. There's huge problems. Having said that, what I find really interesting is I was on an extended visit last year, and because of my age, you're concerned about diabetes. So I'm away from my GP, right? But I want to keep my eye on things. But you can walk into a clinic here and you can pay 130 dirhams, which is about 40 quid, and get a full assessment, blood tests, and a GP assessment as well with a follow-up appointment, right? Without really waiting at all, right? So I found that quite interesting. But to me, the key point there is about education, right? And the advantage that people have who know and understand. Not everybody could pay for it, and not everybody would necessarily understand. But what I do notice, particularly out here as well, is that people who have not succumbed, shall I say, to Western, are a lot more diet conscious. All the people I speak to, the educated people, are a lot more conscious of the diet than possibly we are in the West as well. So it sounds like I'm talking a bit of a jumble, and it is a bit of a jumble, but I think there has to be a conversation. And I think that was one of the things, if I recall, John, you said right at the head of this discussion. Who's going to break the ice, right? Who's going to start having the conversation about the real situation, about different systems, how they're integrated, taking the best of the best, and really understanding what's going on? Because people, nations are working in silos to a certain extent, cultures are working in silos, and then you've got the pharma dimension that you mentioned as well, and there's the question of wealth too. So it really is a multifaceted problem that somehow humankind has got to find a solution to. Does that make sense?
It makes a lot of sense to me. I think that the majority of people that I worked with and helped when I was a GP are very much stuck at the level of the surface, and it's whether and how the changing that discussion is brought about, and what the change agents are, who the leaders are that actually give us permission to do that. And part of the problem, if going back to the conventional kind of health view of it, is that changing a system which costs 157 billion or whatever it is in the UK, 157 billion pounds per year, and struggles despite that huge amount of money, how you cope with the double running costs of setting a new system up without completely breaking the existing and doing away with it. We've already moved, I think in 1948 when the NHS was started, the slice of GDP was probably 12%. I think it's now 37% for health. So it means that whole bunches of other departments have a much smaller slice of national wealth already. And my analysis and reading is that actually there is a significant risk that conventional healthcare within 50 to 100 years will become totally unaffordable.
Yeah, I can see that based on the numbers. And we've got a situation, certainly in the UK, where we have a contracting economy, right? And the GDP per capita is going down and not up. So the situation is only going to get worse.
So, and going back to the discussion about the amount of sickness in the community, during the last 30 years, it's interesting that life expectancy has increased by a significant amount. I think over probably longer than that, but in the UK, it's moved over, say, 50 years, from late 60s for a man up to late 70s or early 80s as life expectancy. Life expectancy with fitness has increased by 1 or 2 years. Life expectancy living with disability caused by chronic disease has increased the remainder. And there is part of my solution would also be to introduce a discussion around at what point does quality of life become more important than quantity of life, so that we don't prolong life artificially and unnecessarily, which is, it has been debated. There's euthanasia at one end of that, but it doesn't have to be euthanasia. It's whether you keep throwing antibiotics and keep doing interventions in all sorts of situations. And that would be an easy thing. So as part of a social contract, I can envisage that if you take any state benefit, which includes pensions and healthcare, then you could easily go through a 10-yearly, once every 10 year, 2-stage validated interview system to say, look, we don't mind what comes out of this discussion, what your option, what your choices are, but put into effect essentially something like a living will that says, how do you want to live if these situations do occur? And it wouldn't solve the problem of the health service on its own, but it would be a tool to show that different solutions and different ways of thinking are important.
It's really interesting you say that, because the sort of, you know, and we're not comparing health systems around the world, you know, with insurance-based systems and everything else, but what you see is absolutely fascinating for me, is because there is a base assumption on the current system that everybody has access to everything at any time, almost in perpetuity or until they die, right? And that paradigm and that question isn't being you know, challenged at the moment, and maybe we should, because, you know, people talk about fair society, you know, I mean, again, we're deliberately keeping away from the political here, but, you know, people have mooted health credits, for instance, you know, and systems like that. But at some point, there's going to have to be discussion, as you say, about these things, because otherwise the system's going to implode, and then nobody's going to serve.
Or on that, John, there's two levels to the way that I think. There's like the strategic central redesign level, and then if you put yourself at the sharp end as a practitioner, having to say to a poor unfortunate person, actually, we can't afford to do that, and the response that person has, you know, that in itself is a skill that has to be acquired, and you have to explore that with the person and encourage them, help them through the thought process to make a balanced decision. And the way that we're going, that process will be run by AI. And the soft, cozy, touchy-feely part of medicine and response, and maybe, you know, a good AI robot will be able to be very empathetic and have all the EQ in the world, but maybe it won't. And then, you know, then it becomes a bit like some of the rather dysfunctional films that you see with of the future.
No, absolutely. Future. Yeah, and it's a very interesting point. And then, I mean, that opens a whole can of worms about the algorithms inside AI and cultural bias. I mean, I was at a talk at Cambridge a couple of years ago about that too. So yeah, that's just absolutely fascinating. There's a couple of things I'd like to come back on, but I'll wait for the moment, Ben, because again, you were listening there patiently. So any thoughts and reflections?
Yeah, I think I think what you're pointing to, and I'm definitely interested in, and again, maybe there's this you know, different value system, you know, a change of perspective when we move to focusing on quality of life versus, you know, absolute quantity of life. And yeah, I've wondered that about that for a long time, that and this is difficult to measure, takes more time, but actually maybe that's what I was pointing to when it seems, or this kind of perception that actually maybe people's experience of life, having more years experiencing chronic illness is maybe what I was picking up on. You know, I don't know the exact figure, but there's a huge percentage of our you know, health system's budget which goes on the late stages of life, as you say, kind of keeping people alive. So there was something about you know, also our society in many ways is scared of death. You know, we haven't really got places like we used to have religion and the church and community and relationships, which would help us deal with tragedy. And I think that actually part of the transformation is this rebuilding of community, rebuilding of you know, relationships, and actually maybe we need rituals to deal with you know, the loss of people in our lives. So there's something there which I was you know, wondering about, and it's a really complex change that we'll have to go through as a society. But then the thing that, just going back to personal reflections on, and you pointed this out early on, John, I'm just going to go back to maybe the more we talk about illness and sickness, the more we notice in ourselves and other people. And there's this paradox, because I've had a few mental health challenges, like many people have, and actually being able to talk about it, and we're a lot better societally, talking about mental illness now. But I find that actually, if we end up talking about it too much, so there's this kind of sweet spot that actually just talking about it and being able to talk about it is helpful. If we only talk about that and we only see ourselves through this mental health or mental illness lens, we end up basically fulfilling that identity. And so we talk about relationships with things like food. And I think there's interesting studies that actually, if you think positively about the food which you put in, but a bit like placebo effect, you're more likely to process it in positive ways. Where actually, if you have this really unhelpful relationship with diets and your body image and everything else, that actually that psychology changes how we process things, which I guess makes intuitive sense if you think of this as a system. So I guess I'm just trying to connect this bit where you're saying that actually there needs to be a leader which says actually this health system, is broken, and being honest. And at the same time, all of us are talking about illness, or a lot more of us are talking about illness, and actually what that will cause. So I'm just trying to think of the effect in society that will cause.
Okay, so that's interesting, and again, we seem to be very much on the same kind of page. But if you think about inputs of medicine, the risk is that by doing something, you actually do more harm than good. And the easiest thing in the world in medicine is to say, yeah, I'm going to do this surgery, or I'm going to give you this tablet. And the patient is relatively quickly satisfied because they've got a positive action. The hardest thing is actually selling. Actually doing nothing is the best approach.
It's really interesting.
A GP consultation, less so now, because the perception about benefit of antibiotics has somewhat shifted. But 15 years ago, the discussion with your average patient about antibiotics for a sore throat, it took 2 minutes to say, oh yes, you got tonsillitis, have some penicillin and go away. It would probably take 12 minutes to try and persuade someone that they don't need antibiotics, and you'd still end up giving them a prescription saying, well, if after 48, 72 hours it still hasn't improved, then you better take it, knowing full well that the evidence didn't really support that. But you had to give a lever to enable the discussion in the first place, and a way of at least closing the discussion to get the patient out the door without complaining about you. So those kind of things have happened. Another example would be that a lot of interventions can be counterintuitive. So if you think about type 2 diabetes, which is the later onset, so-called in the past non-insulin dependent diabetes, you would have thought that giving someone a blood glucose monitor to monitor what their blood sugars are doing would be a successful and useful tool. The reality of it is that you actually introduce more health anxiety, depression, and poorer outcomes by doing that in an unstructured way. And it has to be used as an intervention at the right time, when the patient can use the information to convert into lifestyle changes.
That's fascinating, because what you've just described to me in both of those cases have huge psychological processes involved in those, right, to get to the right outcome. So it's not just pure traditional science that's involved, it's psychology as well, right? And the way the brain thinks and how it perceives the intervention. So I think that, that in itself is fascinating. Just one thought, I think, and then, I'll hand over to Ben to sort of talk about some potential sweet spots, because we've had a very rich discussion and close out. I was, as you saw from a bit of the framework, going to talk a bit about different healthcare systems, around the world, and, how the structure of that is. And, you touched on the early triage, which you believe in at the start and everything. And I'm beginning to wonder now, based on this conversation, is that the problem's way bigger than that, right? Based on what you've described, John, not, tinkering around the edges in terms of some of the systems. And I was, one of the things I touched on the lean work, something I was interested in, we've got the advantage of robotics and AI and precision surgery. And one of the conversations I've had in the past with surgeons is around what they call mistake proofing, which again is typically what we do in manufacturing. When we make car parts, we try and make them in a way that you don't make a mistake. You manufacture them so nothing goes wrong. You could argue the same with surgery. But I'm just beginning to wonder now that in reality is such a small part of the overall health system problem that, arguably, is it worth pursuing? Does that, am I resonating in that sense, John?
Well, you're resonating hugely with me, but you wouldn't resonate with the bulk of doctors and health managers. Forgive me if I segue a little bit again. My belief is that the vast majority of managers and politicians do things because they believe they are doing it for the right reason.
Mm-hmm.
They are not coming to the same conclusions as I do. And so if, for example, going back to Shipman, for example, GP who killed off a load of his patients in the UK, the knee-jerk reaction to that was starting the system of CQC-like bodies and GP appraisal. Now, when that was begun probably 20 years ago, something of that order,
mm-hmm.
The industry which has now built up through that approach is immense. The benefit to the individual practitioner is fractional. In my perception, the reliance that, again, from my perception, based on lots of experience, the reliance that managers and politicians put on that is disproportionate to the benefit it actually provides. And the fact that you are taking resource and workers who have to be experienced out of the coalface and putting them into the industry which is so-called improving quality actually leads to a reduction in overall quality in due course.
So you and I could have a good discussion on this all day, because that exactly my thinking. I'm thinking of an author that both Ben and I like, Nassim Taleb, the Lebanese mathematician and philosopher, talks about skin in the game, about we're all being run by technocrats and bureaucrats who love that sort of stuff. What you've described to me is a huge administrative monster that actually has a very small fractional volume. And I know in corporate world, it used to really annoy me was that they do expense audits, and which is important. You need to get control of falsifying accounts and expenses, but you'd end up with one expense report that was fraudulent in a region, and all of a sudden they develop a new system instead of actually dealing with the one person, getting the message out and saying, if we caught, we're going to punish you. And then all that net effect does is it increases the administrative load of people who should be doing other work and adding value.
We won't go there because it would take a hold of the Zoom meeting, but that we could have a very long discussion about different ways of approaching the Shipman kind of problem, which would be about looking at trends and so forth. But let's not do that. The bit that you were saying whether the health systems elsewhere, it's just, I can't remember your exact words, John, but whether just doing some bits that we've been talking about actually are not large enough to reform the systems.
That's basically, that was my question, yeah.
I come back to the fact that it doesn't matter which health system you're in, people are struggling with the affordability and the training of staff and the number of staff. And there are, if you, and even there's an interesting graph that I could point you to from the King's Fund, where the Chief Finance Officer did it, well, it must be about 10 years ago, which looked at health outcomes by system in 12 systems around the world and extrapolated where they were likely to be in terms of affordability over the next 50 years. And then they looked at two outcomes: that people started actually taking more care of themselves by making sure that their diet was healthy, that their weight was controlled, that they didn't drink so much, smoke so much, took exercise, etc., which was obviously a lower trajectory than we carry on as we are and have poor health generally throughout the community trajectory. What struck me was that using the going on as we are trajectory in America, by 2067, I think it was, or even 57, 100% of GDP would be consumed on health using the American extrapolation. Right. And so I come back to the fact that probably modern medicine, done in the way that we do it at the moment, is not affordable. So another elephant in the room that needs to be addressed. Instead of saying that everything's sweet, we'll keep building and pouring more money into it, surely now is the time to have that conversation. This is as big an impact on people's lives when they can't get healthcare as probably the influence of climate change on their lives.
Yeah, without a doubt.
Yeah. And when it becomes more personal, because all of a sudden you've got a disease that's going to kill you and you can't get any care, people will react much more strongly about it. The time that it is going to take to change the system is pretty much in line with the time we've got available. And so if we don't start soon, there will be a fairly horrendous future.
Yeah.
I'm sorry to be bleak, but climate change is that you're allowed to be bleak with climate change. So I'm just saying my version of health reality, and it will become those that can afford will get, and the disparity in health outcome will just grow and grow.
Yeah, it'll become more elitist over time. I mean, what you've described to me, mathematically, logically, sensibly, psychologically makes absolute perfect sense to me. And I applaud your candor, in terms of comparing it to other problems that we've got within the world, like climate change, because I would totally agree with you. I think there are other ones as well, but that's for another debate. But I think, I'm really appreciate all the input. But Ben, would you, it's interesting, we started off with prevention and curing, which was a good stimulus for the conversation, but I think we've gone way beyond that, and I'm wondering where the sweet spot is. It feels as though the sweet spot now is, let's have a conversation that we need to have urgently around the macro situation around health. But Ben, any reflections on that as you close out?
Yeah, I think just very briefly, you're probably aware of the Core 20+5 strategic vision project, the NHS, John?
Oh, wow, okay. I'm probably a bit out of date, but yeah, that's a
inequality.
That's a revolving wheel, and that will be the iteration that is currently there. Then.
Right. Okay. So these again are like sticky plaster solutions or projects, branding exercises, or something a bit more meaningful than that.
They're good for immediate partial benefit. They don't transform the system. And without transformation, I don't think it's sustainable. So, they're useful as long as we got the current system.
Okay, it's good. It's good to know. Yeah, I guess to John's point, that we've covered so many different things, and there's the administration central part of the system, and then there's the local on the ground part of the system. There's whether to intervene or not to intervene. There's whether to cure the surface level symptom or kind of prevent the deeper causes. There's so many different sweet spots which we've talked about, John, probably more than most of our conversations. There's the quantity quantity of life or quality of life. There's kind of really really interesting questions for people to ponder. But I guess I might leave it with you, just as a thinking ahead to this 15-year transformation, or this 15-year conversation and transformation as we try and figure out a new health system. What might be some of the new features of the system, and how might we, what might be some just different features of this new system? Because I'm conscious you've pretty much written a book about the health system, and looking ahead, what might just be some big changes that we think about?
Well, I'm going to do this bit first because I think it is absolutely crucial in the UK to give an environment which allows the range of change which is needed. And so that would be decoupling of the political leadership of the NHS from the centre, a very centralist bit. And it's no mistake that 3 cross-party ex-secretaries of state for health have suggested that a royal commission actually looks at redesigning the NHS and basically setting the criteria that the NHS can afford to run by. And I think an approach like that, and if you go back to the start of the NHS, it was actually done in a similar way by reviews of what are we trying to achieve and how are we going to try to do it. That, to my mind, is crucial. We've got to get away from linking things from politics and the immediate knee-jerk reactions that come from that. Without doing that, all the rest of the bit that is necessary to allow the transformations and to get personal responsibility for health better, to use AI, which I really do think could provide a whole load of benefit at the lower end of healthcare, could be used better, to get factors around nutrition, general welfare, environmental issues, food issues, and so forth considered. They've got to be given strong permission, and strong permission needs a leader or a system of leaders or something to facilitate that, to get into the domain of healthcare, to counter the inevitable inertia that pharmaceutical companies and unfortunately a whole load of doctors will fight against. And we then also need the debate about the quality, quantity of life, affordability, how do we set those limits, which probably needs something like the Paris Accord. Every country has the problems, so why don't we all get together and think about how we could start fixing it globally, and putting some top level rules together, if you like, and influences.
I mean, you put it so well there, John. I mean, you've just described what we would call in the coaching way is creating a psychologically safe place for people to be challenging, creative, without fear, threat, or favor, in order to solve problems.
John, I've got so many bruises from threatening to think outside the box that safe place certainly doesn't exist at the moment.
No, I can well imagine. So, I'm just looking at the clock. We've been going on for quite a considerable time, which is brilliant because that means we've had a fantastic and rich discussion. So, just Ben, final thoughts on closing and reflections.
No, I think I won't add it. I won't add anything else. I think just what we're trying to do is just be part of that process and have different conversations about different subjects. And you've been a brilliant guest today, John. So thank you for joining us. It's hopefully it's helped me think differently about the system and about health, and I hope it helps other people as well.
Well, from your point of view, one kind of thought, because as you say, I've been writing this book, or partially doing it some of the time, but the one place of influence is basically, I think, management school for the NHS, because we are turning people out in both medicine, nursing, and NHS managers with they're like clones of the existing. You're not allowed to have any critical thinking. You're not allowed to challenge the system. You're not allowed to say, no, you're wrong. And unless we can give permission to doing things differently, we will be in a poor place to actually face the challenges. So any influence at that level would be, very welcome.
I will certainly, I'm sure Ben will too, give it some thought. It just reminds me finally of a wonderful quote I had from a guy from British Steel who was an industrialist, and they were talking about the early quality standards that then became ISO standards, which was BS 750. And somebody in the audience said, oh, don't worry, we'll get a quality standards, BS 5750 will fix it. And he said, no, the only thing that 5750, which was a piece of, effectively process and bureaucracy, is it basically said if you're currently making rubbish, you will continue to make rubbish with no opportunity of making anything else but rubbish. So I think, to your point about being clones, and having critical thinkers and moving outside the box, I think is really well made. We need more critical thinkers and more people thinking outside the box, which again is partly what's one of the main raison d'etres for Sweet Spot Safari. So again, a very personal and warm thanks from me to you, John, as well as Ben. You've been a great guest, and it's a wonderful conversation.
Thank you.
Thank you. Until next time, take care.
Take care.